All right. So this first thing I'm going to be talking about is not, I wouldn't say it's like test related. I don't think I have anything that's a test question on this. Um, but it's crucial. Understanding this is crucial to understand why we're learning everything we're learning. When you ask me a question and I give you a vague answer, the reason I give you a vague answer is because of what I'm about to go through. It's also what your entire career is. So even though there's not a question, I don't think question number 3 on the first exam is going to say, what did Josh talk about at, where did that clock go? Uh, it's time to go. It's almost time to go home. Start packing up. At 9:35, day one, Josh said this. It's question number 4. No, this is something for us to understand of why we're doing everything and why we're learning everything. So, our patients become our patients because something happened to them, right? Does anybody ever just wake up and be like, man, it's great. September 5th, it's going to be one of the nicest days of the year. Feel awesome, happy life, birds chirping. I'm going to go to PT today. Does that happen to anybody? No, right? So something has to happen to make that person seek physical therapy. What are some of the things that it would cause that would make them seek physical therapy? What's that? Car accident, great. No, not for them, but yeah, for us, yeah. Yeah, car accident, great example. Absolutely. Anything else? Different surgeries. Give me some examples of surgeries. Hip replacement, knee replacement, very common. Good. Any other surgeries you could think of that would? Cardiac surgery. Yeah, I was hoping we get out of musculoskeletal, but yeah, musculoskeletal. This muscle, tendon, bone is a problem. We can go fix it, or this heart's a problem, or this brain is a problem, right? So yeah, different surgeries, heart attacks, different heart conditions. We shouldn't just say heart attacks, different brain conditions, not just stroke, but yeah, definitely great examples. Any others? Those are the big ones I wanted to hit. Great. So all of those things, it doesn't matter if it's an accident, a planned surgery, a not planned surgery, all of those things that they cause a change in that person's life, right? So the way to think of it for our patients is they have a prior level of function. One of the other things I will say is I try not to use abbreviations. And it's always amazing when I say like, oh, I don't use a lot. To all of my PT circles that are PTs and PTAs, I say like, I rarely use abbreviations. And then when I hear from students, their number one complaint is always what? I use too many abbreviations, right? So I think I don't use a lot, but then in your shoes, you say like, this guy, what is he talking about? So if I ever put an abbreviation, you don't know what it means, please stop me because I don't realize I'm doing it often. All right, so the person has a prior level of function. And then something happened. So they have some sort of mechanism of injury or illness. So that's the car accident, that's the knee replacement, that's the heart attack or stroke, right? That what is the thing that changed in their life? That thing is going to change. Now the patient has a chief complaint. Perfect. Thank you. This one we can chuck. Yeah, thank you. Ah, look, this will be great. Thank you. So does everybody who has a car accident have the same complaints? What are some of the things that a patient who had a car accident might complain about? Because there's a big broad spectrum, right? So what could it be? Could be simple whiplash, neck pain, it hurt, I can't move my neck, right? It could be that. What else could it be on like a way more severe spectrum? Shattered leg, yeah. Spinal injury, right? So we could go crazy with this. So even though the mechanism of an injury could be the same, the chief complaint of the patients can be really broad. Now, you had a lot of orthopedic. Have you worked in a clinic? Is that why? So does every single, saw a lot of knee replacements? Does every single knee replacement present the same exact way? So somebody with a knee replacement, some people, it's the pain is the number one thing they have a problem with. They're walking around okay, but they're just in a lot of pain. Other people, the pain is not that bad, but there's a lot of swelling, right? So they both had knee replacements. They both had the exact same surgery, but their chief complaints are way different, right? So that's where we get a lot of variability between our patients. Perfect, thank you. So those complaints will lead us to impairments. The knee replacement example is I have so much swelling, I can't bend my knee, right? So the impairments are the problems with the body. I can't put my weight on this leg. I can't, walk, all of those other things. And those cause a change in life, right? So when someone has a whiplash neck injury, is their life the same? Might not be drastically different, but anybody ever have a lot of neck pain? Right? So how's sleep go? Not great. How does going to the gym? What do you think? Bad, right? How does walking the dog? Especially when there's what's that? Looking down a right. Yeah, being a student, driving, even like reading a book or texting with friends, right? So these problems, the chief complaints and the impairments, cause a change in function. So we call that current level of function. This is what I call the patient's journey, right? They had a prior level of function, something happened to them. Now they have complaints and impairments that change their function. So now we have to talk about what can physical therapy do? What's the considerations? Let's do considerations instead. Do you think knowing about the patient's prior level of function is important? Yeah. Yeah. Why? Yeah, eventually we want to get it back there. Knee replacements are easy examples. To walk downstairs safely and efficiently, you need 105 degrees of knee flexion. That's it. How many people have aid tech experience? So you guys have all seen knee replacements before, right? The rest of us will just have to imagine. All right, so after a knee replacement, getting that knee to bend is painful. It's tough. Nobody wants to do it, and it can sometimes be really difficult for some patients. So we need 105 degrees to walk downstairs safely. Do all of our patients walk downstairs all the time? No, no. Now, toughest ones that I've had after knee replacement are these church-going little old ladies that tell me, Josh, I have to kneel at church. If I don't kneel at church, I'm not going upstairs when it's all over. And I go, all right. So in order to kneel efficiently, you need a minimum of 120 degrees to kneel in those, right? And to kneel at church. All right, well, that's a lot different now, right? That 15 degrees for our people with tech experiences, how easy is it to get 15 degrees for after a knee replacement? Sometimes it's a real slog, right? So that's way different. So knowing about that patient's life is crucial. So that we could get way bogged down into a lot of details right here. The big things is so my 4 categories: self, environment, intrinsic, and extrinsic factors. So for myself, when I'm talking to my patient for the first time, the conversations I'm trying to get at, what kinds of things do the patients do for themselves? ADLs is the first thing I have to think about. ADLs, you guys know what ADLs is? Activities of daily living. So, in the past, before all of this mess happened, did you dress yourself? Did you bathe yourself? How are you doing getting in and out of bed? Do you make breakfast for yourself? Do you cook for yourself? Right. So that's the kind of basic, can you support yourself is my first question. Not everybody does, right? We have, I'll get into what my career is like in a little bit. But not all of our patients take care of themselves already, right? So what is that? Work and fun are my next 2 categories, right? Because I need to know, how are you spending your days? I have patients who spend 22 hours a day in their recliner in the living room. They sleep in the recliner, they don't go to bed, and then they sit in the recliner watching Maury Povich and Days of Our Lives during the day. So Maury Povich is great, by the way. One of my guilty pleasures. You are not the father. No. So what do you do for yourself? What do you do for work? And what do you do for fun? The next thing that plays a big part of is environment. If my patient has a knee replacement and live in a 3rd-story apartment with no elevator, that's a much different patient than someone who has a 1st floor, just ranch house, no steps to get in. Very different, right? If someone who lives by themselves right now, anybody just live, no roommates, no family, very different than if I had one patient, there were 3 generations living in one roof. There was always someone around. So do very different things, right? Grandpa needs a cup of water. Who can get it for them? 3-generation household, someone's always around, or someone will be in the next half an hour. We live by ourselves. That's a much different level of function we have to start considering. Now, intrinsic and extrinsic factors, intrinsic within the person, things like age, other comorbidities and past medical history, motivation levels. Not all of our patients are motivated to get better for a lot of different reasons. Any of our techs, anybody ever come across somebody who doesn't want to get better? Yeah. Give me some stories on that. Give me some examples.
The total lady and just you worker sit around.
Yeah. 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 It's amazing. Why did you get this done in the first place? Like, what did, yeah. Did your knee hurt while you were sitting there? Why did you get this done? Yeah. Yeah. Hey, but you know what? I will argue that there's something we didn't hear from the patient. If our treatment, so think of this, and for the techs that have some experience, it's easy to think. For others, think you'll get it too. If our exercise for as the physical therapist assistant says, you're gonna do squats, lunges, you're gonna walk on the treadmill, you're gonna ride the bike, we're gonna bend this knee that I know it hurts, but don't worry, we'll get this bent further. And the guy is saying, I don't want to do any of this. I just want to be able to walk to my bathroom without falling down. Isn't there a big disconnect between what our treatment is and what the patient actually wants? Even though the squats and lunges and biking and walking and treadmill is all good, yeah, maybe we should just listen to the patient and really tailor. Maybe this guy doesn't need an hour-long session. Maybe he only needs 40 minutes and we just attack the swelling and we just go slow with this guy. Yeah, I think there might be some disconnect between the treatment plan and what that patient actually wants. But it's a good, really good example. Any other examples of patients that don't want to get better? He's always, yeah. I've had, man, I've had plenty of those. Yeah. Yeah. I had one guy, construction type work, big back surgery, workers' comp case. He had 5 kids. And at one point, you know, I'm saying the same thing that other PT working with your guy with a knee replace probably was saying. You know, we're gonna get back. We're gonna do this. Don't worry. I'll get a sledgehammer in the back. We'll practice. We'll make sure your back can do all that stuff. He looks at me one day. He goes, Josh, I'm not paying daycare for 5 kids while I'm out of work. I am making so much more money not working. I'm never going to go back. And I go, okay. I'll leave the sledgehammer out there then. I don't, you know, fine, right? So not all the time our patients don't always want to get better. So that's one of those intrinsic factors. Makes our job a lot harder when somebody doesn't want to get better. Sometimes our patients don't want to get better because they're depressed. Sometimes they identify with whatever there's wrong with them, that if we took that away, we're at changing their identity. Anybody ever, I know everybody in here knows someone, whether their family or someone else they've talked to, that the only thing they talk about is their back pain. And if we took away their back pain, what would they have? What would they be? Right? So that, man, that gets really tough for us. So intrinsic factors, man, that can be really tough. Age is an easy one. Who gets better faster? A 22-year-old or a 52-year-old? Yeah, easy, right? So age is part of it. Extrinsic factors are things like how much free money do you have around, your living environment. I've got some people that if they had that knee replacement and their bedroom was on the top floor of the house, you know what? We'll just move the bedroom to the living room for now. You know, the dining room, we'll move the dining room chair to the garage. We'll just put the bedroom in here for now for, 6 weeks or so. I have some people that can do that. Not everybody can. So the extrinsic factors of all of that, what money do you have around and your living environment, pets, All right. So understanding about the patient is really important Man, we've already talked about it, right? Understanding that the patient doesn't want to do a bunch of squats all day long. They just want to sit and watch Maury Povich with me. So yeah, we've really got to understand that patient. For me, I worked in Middletown for the first, what was it, 6 or 7 years of my career. Anybody from Aquidneck Island? Anybody? So on Aquidneck Island, there's a ton of engineers that live on Aquidneck Island. There's defense contractors. It's real hotbed for engineers. So I've had a bunch of engineers as patients, and I love them because they're really analytical thinkers like me. They want to know the mechanics, and it's great for me. But here's the thing: if I just said, "Oh, you're an engineer," great. I've had engineers that sit at a desk all day long. I've also had engineers that have to go scuba diving to inspect underwater piping for their welding to see if it's going to pass inspection or not. If I didn't know that about my patients, I'm just going to, wow, this guy's just going to sit at a desk all day long. I don't have to. No. You've got to go scuba diving to get very different, right? So we've really got to understand our patients. Now, that's the prior level of function. The mechanism of injury. I've got a few things that I like to think about as far as the mechanism of injury. Is it static or progressive? That's my first question. My next question is it lifelong or temporary? So why would somebody have a hip or a knee replacement? What made them get one? Because they had what condition? Arthritis. So osteoarthritis, is it static or progressive? It's progressive, right? The first time you get an x-ray and doc says, oh, you have a little bit of arthritis here. Guess what? In 10 years, what's going to show on that x-ray? A little bit worse. Yeah. We don't know how bad. We don't, it might not affect your function, but yeah, it's getting worse. What are some other progressive conditions, do you think? Tough thinking. Tuesday, right after Labor Day, and I'm asking all these questions already, and we haven't even had a class about diseases, and I'm asking you for answers about diseases. Yeah. MS, multiple sclerosis, progressive condition. Yep. ALS. You guys. So I do home care for my patient care right now. I have been for a few years now, and I don't see a ton of patients because I'm spending a lot of time here. Two of my 3 patients I have right now, one has ALS, one has MS. I saw them both yesterday. How about that? Isn't it? Yeah, it's really complete the trifecta. Yeah. Another progressive condition, right? Parkinson's. Yep. So, how about static problems? To keep in the neuro field, you've got a big neuro mind, huh? No, all of your examples and answers are neuro-based. What was your first neuro-based question answer when we talked about mechanism of injury? It was what? Car accident that caused spinal cord injury, right? Spinal cord injury, car accident, spinal cord injury, static or progressive? Static. Yeah, you get one, it's done. Like we got to figure out what happens after. But yeah, it's not. You're not going to have a car accident and the doc 10 years later says, well, you had another spinal cord. No, you need another event to have that happen, right? It's good. Any other static conditions? Whiplash, static, right? It's going to hurt for a while, but it's static, right? Broken bones, yeah. Physical injuries, yeah. Static, it happened once. We're all done, yeah. Lifelong or temporary. So that's where all of our first examples, MS, ALS, Parkinson's, all lifelong conditions, right? They're not going anywhere. Spinal cord injury, yeah, lifelong. It's going to be around for a while. Whiplash, temporary, we hope. We hope. Some other reasons why it might linger for longer and longer, but we hope. Yeah. Knee replacement. So the knee replacement is going to be lifelong, but hopefully the impairments are temporary, and just for now. And actually orthopedic, replacements, hopefully we get the patient even better their prior level of function, right? So so those are some of the questions I ask myself. So the reason I'm spending time on that part right now is because you guys are going to ask me questions. Josh, would you do this if, and my answer is always going to be, it depends. It depends because I don't know, is the condition static or progressive? Is it lifelong or temporary? What was their prior level of function? All of those factors are really important to figure out, what am I going to do with my patient today? Is this important or not? My patient with ALS, he does okay on stairs, not great. Should I spend a lot of time working on stairs with him? You say no, why? He's progressively going to lose that ability anyway. Yeah. The best thing I can do is convince that family to put in a ramp as fast as possible. Because guess what? You're not going to be leaving the house by yourself. You're going to need somebody physically moving you soon enough. Yeah. Yeah. Sad to think about, man. It's really tough, but absolutely. Yeah. So today, am I doing a bunch of stairs with him to get better at stairs? No, I'm going to do a bunch of exercise with him to preserve as much mobility as possible, to fight the decline as much as possible, but it doesn't have to be stairs. Yeah. Yep. And that's also something I shouldn't promise a family. Don't worry, we'll get better at stairs. We can work on it a little bit, but if we actually get better, it's a bonus, because guess what? We're not going to be better for long. Yeah. Yeah. So all of that stuff really, really impacts our decision making. Now, the chief complaints are the issues that patient identifies. So we need to listen. After knee replacement surgery, eye care, does it bend better? Does it straighten out all the way? Is it swelling control? Can they walk? Can they do stairs? Do they have power to not fall down, right? The patient's complaint is always pain. I don't care about their pain. But if I told my patients every time they complain about pain, well, I don't really care about that. What do you think would happen? I wouldn't have a lot of patients left, right? So even though I really don't care about their pain, because what's going to happen with their pain if I do my job on all of the other problems? It's going to go away. And guess what? If I never met the patient and they never had PT in any kind, and they just waited 8 weeks after surgery, how's their pain going to be? Pain's going to be a lot better. There's some danger to that, but the pain's going to get better as their body heals. So that's why I don't really care about their pain at the knee after a knee replacement. But guess what? If I just told them that, then they wouldn't be my patients longer, right? So I need to listen. And I need to make sure that I understand what they're going through, because there might be some clues that I'm missing something. So it's crucial. I don't want to gloss over that fact. We have to listen to our patients and really think about what they're saying. But usually their chief complaints are going to tell us what their impairments are. The impairments are the things that we can measure. So we measure. Why do you think it's so important for us to measure our patients' impairments? To detect progress. Number one reason, I think, is to detect progress. Most of our patients, they will progress, except for the 2 patients you guys gave me, my patients that I'm going to be seeing. Why is it important? If I know these people are going to, if my patient with ALS, if I know he's going to decline, why am I measuring? Measure the rate of decline. Yeah. Yeah, definitely. Yep. And actually, as different medications are around, and I'm not a med expert, especially in the neuro world, I can tell the neuro team that this person does have, here's what I did on day one, here's where we are now. And with that information, the people that know a heck of a lot more about ALS than I do can start using that data as part of their decision making too. So yes, it's not just me making decisions for that. So we measure to measure progress. Or to do what, Tate? Yep. So we use it to make decisions. On treatment. TX is treatment. And the other category is safety. Anybody think of an example on something I would measure to see if it's patient safe or not?
Oh, sorry.
Could be, could be. Yeah. Yep. Yep. Potentially. Yep. Yep. So I know if the patient doesn't have a minimum of 105 degrees, they can't walk down their stairs. What we would consider normal. We don't like using normal in our world, but they can't just take a step down. They have to go sideways. They have to have some sort of other compensation. And guess what? If there's not a railing and now they have to go sideways, boy, it's becoming unsafe. So yes, sometimes that can do it. Guess what? Another one, especially as we work with our more geriatric population. I've had one patient walked into their house, took their blood pressure, their resting blood pressure, as I walked into the house, was 210 over 100. Am I going to get that guy doing a bunch of squats and walking up and down the street and up and down the stairs? What do you think would happen if I did that? Something's going to explode here. Right? Right? So yes, the safety, first thing, are we safe enough to actually participate in physical therapy today? So if I do that, man, if I know the impairments and I can measure them, I can treat them, I can improve the impairments, and I'm going to do something. So I have three goals for physical therapy. Each patient needs one or a combination of these three goals. You've already told me number two. Return to prior level of function. For the bulk of our patients, that's the goal. Return to prior level of function. You fell down, you had a car accident, you had a heart attack, you had a stroke. It doesn't matter. Our goal is to get you back here. Now, depending on the severity of impairments and whether it's static or progressive or lifelong or temporary, like we might not always get there, but that's the goal for most of our patients. The two other things, the first thing we try to do improve current level of function. That's my number one goal. My first goal with any single patient, improve your current level of function. With considerations on their environment and their intrinsic factors. My woman who has MS that I'm seeing, the number one goal she has, she's lost the ability to transfer to her toilet independently. And her family is always in and out. There's never somebody there all the time. There's periods of the day where she's alone by herself. She loves drinking a cup of coffee. But after the cup of coffee, shortly after, she has to go to the bathroom. So if she knows her family's not around, she doesn't enjoy that cup of coffee. My whole goal, get back to transferring on and off the toilet. That's just maximizing her current level of function. Am I gonna? She uses a scooter for locomotion now. She hasn't walked in 15 years. Am I gonna get her walking again? No, I'm not returning to prior level of function before she was diagnosed with MS, right? So, that's some patients. It's our entire goal. For our patients with knee replacements, for you techs, isn't getting in out of the car without pain, isn't that improving current level of function, right? Getting them so they can drive, getting them to that power if it's their right side so they can actually press on the brake and be safe driving. That's improving current level of function. Yeah. So improve current level of function. The last thing, minimize future complications. So for our patients after a heart attack, heart surgery of some kind, I'm going to get them better. I'm going to definitely improve their current level of function, depending on how bad the heart condition was that caused this whole mess. I might return them to prior level of function. But guess what? Part of my job is to also say, Larry, I've loved working with you. You had a massive heart condition. I know you've got a bunch of docs telling you exactly what to do. I'm going to echo some of the things you've already heard. And I'm hopefully going to tell you a couple new things too. But the other thing I want to make sure you understand is I'm always going to be here for you. If you have a question, call me. You're 70 pounds overweight. Your diet's terrible. You don't have a control of your diet right now. And I know you've got your cardiologist telling you you need to fix your diet. Have they set you up with a nutritionist? No. Would you like to talk to one? Because I'm not an expert in nutrition like you need to be for your level. But if you want to have another heart condition, you can keep going on your same path. If you want to reduce your weight and improve your nutrition, I know some people that can help you. Minimizing future complication, that's definitely going to be part of what we do. My patients who come to me with just fall risk, they had a level of function, they've fallen. Now we're wondering if grandma can still live at home or not, right? I get her patched up and we're doing really good. Hey, you got to remove those throw rugs. That little runner rug that you got, that's going to trip you. We're now walking with a walker. We got to get rid of it because that's going to trip you up again, right? So minimize those future complications. So that's all of what we do for physical therapy. Does that make sense? I know it's kind of a lot day one to sit here and go like, oh, we're just going to spend about 45 minutes talking about our entire profession and what we do. That's right. It's a lot to take in at once. Any individual confusing things? So I'm going to be referring to this a lot. And again, it's not like a question on an exam, but in order to have understanding on why we're doing things and even the courses that you're taking, like all fit into this in some way. We're all learning something that goes into this continuum. So, all right. So how many people are sick of sitting there and listening? Why don't we do this? Let's take just a little water break. So get up, fill up your waters, use the bathroom. Let's come back in 5 or 10, okay? Let's keep going with this stuff. So again, this class is foundational skills for what are we going to be, what are the foundational skills across PT settings? How are we going to move patients who are bedbound safely? How are we going to teach them how to get out of bed safely? How are we going to teach them how to walk with new assistive devices safely? How are we going to measure them as far as balance goes or their vitals to make sure they're safe to exercise today? So it's the foundational skills that we're going to be universal no matter where we might work. It's also the foundational thought process. That's what we started with earlier. So the PT settings we're typically thinking about is hospital. There's a bunch of different sub settings within either within hospitals or different hospitals. Some hospitals are really specialized to certain populations than others. In Rhode Island, we have one special hospital. Does anybody know what that one's? We have two actually, but the one major one. Oh, women and infants. I didn't even think about women and infants. So yeah, all right. So we got another. That's a specialty hospital. I probably don't. I'm not allowed there, right? So it's not. It's not women, men, and infants. It's just yeah. Hasbro Children's is the one I was thinking of. Yeah. So Rhode Island Hospital they're general hospitals, right? They're not one thing, although they might have really good units, but they're general hospitals. So hospital is a bunch of different types of hospitals. We have skilled nursing facilities, SNFs. That's the abbreviated SNF. If you ever hear about SNF, it's a skilled nursing facility. Home care, that's where I do most of my patient care right now and have been for a little while. Outpatient, that's where I started my career. I think that's where most of our techs have been out. Anybody been a tech not outpatient, or everybody's been outpatient? Okay. And then in the school setting, that's another popular setting. So my wife is actually a physical therapist. She's in the school settings. She's at South Kingstown Schools. Any kid with a disability that affects their mobility within their school and affects their learning, she gets to work with those kids. There's others that we can talk about. Academia, that's what I'm doing right here. Sports teams, entertainment production. I knew a PT that traveled around with a ballet. Cirque du Soleil. Travel around the country, patching up all those crazy people doing all that crazy stuff on that. So theater, movies, many more. I'm always amazed how sprawling the physical therapy field can be. But the major ones we're going to talk about are foundational skills: hospitals, skilled nursing facility, home care, and outpatient. Those are the big ones we're going to be talking about. So what is physical therapy? Well, the APTA, their vision statement is transforming society by optimizing movement to improve the human experience. And man, there's a lot of things about the APTA you might be able to complain about, but I think that's a beautiful statement, right? We're optimizing movement to improve the human experience. Isn't that what we're talking about when we're improving current level of function, maybe return to prior level of function, or at least minimizing future complications? So yeah, improving the human experience, because that there was one word in this statement that was, I don't know, 15 or so years old. So I remember when I was in grad school, this statement was heavily debated. There's one word in this statement that everybody was up in arms about. Anybody want to see what that one word is? Human. Yeah, human. Because we have a lot of therapists that actually work with animals. Horses and dogs are the most popular. But yeah, so, but anyway, so most of our patients don't choose PT, right? So nobody just wakes up in the middle at one day and says, man, today is just perfect, let's go to PT, right? Something happens to them to make them. So this is that patient journey and the physical therapy considerations that we talked about earlier. It's here on the slide if you wanted to look at it some more. So our goal is to optimize movement to improve the human experience, either to return to prior level of function, maximize current level of function, or minimize consequences in the future. We'll touch on this later, but the big thing I want to emphasize is the PTA is a clinical-based problem solver. You're a valued team member, but the patient's coming to you and you've got to figure out, what am I doing today to help them do one of these three things? We're going to do that based on the impairments that we can measure. And we're going to provide some sort of interventions to improve these impairments. We're going to improve the swelling. Do you think we can measure swelling, by the way? How do you think we can measure swelling? What do you think? Take a tape measure. Yeah. Somebody's knee is swollen, put a tape measure around their knee, compare it to the other side. Great. So not only do I have a right versus left comparison, but I can also take that measurement again next week to see, hey, did this change at all? Yeah, absolutely. So it could be swelling. It could be balance. There's different ways we can measure balance. It could be strength. Anybody know what we use to measure strength? There's a few different ways we could do it, but manual muscle test, and we'll learn that starting at, is it 2 or 2:30 that class starts? 2? You guys are gonna have to remind me on the schedule all the time. So it could be cardiovascular impairments, right? So it could be either before a heart attack, we've caught them before, it could be after. How do you think we can measure cardiovascular performance? Heart rate, just heart rate. Could be resting heart rate, right? So if we take their heart rate, we do 6 weeks of exercise, what do you think is going to happen to their resting heart rate after 6 weeks of aerobic exercise? It's going to go down, right? Because the heart's becoming much more efficient, right? We can also use heart rate's a great one because we can use heart rate as a measure of, is the exercise challenging enough? It's actually it's I love cardiovascular because it's so cut and dry, you know. We'll get into that later. So we measure these impairments and we treat these impairments to hopefully improve current level of function, return to prior level of function, and minimize consequences. Now, your job as a PTA, the clinical-based problem solver, is to either progress or regress that intervention based on the patient's needs. So when we have the patient you were talking about who says, why am I doing all this stuff? I just want to sit in my chair all the time. The PTA, as the clinical-based problem solver, should really think about that statement and look at what we're doing with that person and go, maybe we don't need to be doing all this stuff today. Maybe he's right. Maybe we do need to do, or maybe we say, listen, I know what you're saying. I understand what you're saying. But if we don't do this stuff, you're always going to have a problem here. And maybe that's just the conversation you need, that patient education. So yeah, progress or regress. My guy with ALS, every single treatment is different than the last. I don't know what I'm walking into. Sometimes we do 10 minutes of exercise and it was a struggle to get to even 10 minutes. Sometimes I'm there for over an hour because we're just doing a great job that day. So it really can fluctuate drastically. Usually not, right? For our techs in here, what typically happens, you make little progressions each time, right? So, hey, that 3 pounds is easy, let's go to 4. Bending it to 100 degrees is easy, we get to 105 today, right? So that could be as simple as it is. Do you guys have any, the techs that are here, do you guys have any examples of when you had to regress something? When you had to say, wow, that was too much, we got to back off? Yep.
Like shoot at 68 degrees deflection, got her like 78, but some days
yeah, yeah,
felt like I was step downs, like a 6-inch step,
yeah,
but some days it's plus, but 3-inch step.
yeah, perfect. Any weather related changes that happens with her? So on the rainy days, we know it's going to be terrible. And yeah. Isn't that crazy to think like it's just a rainy day, we're going to have to go down to 3 inches instead of the 6. Yeah. So being able to be that clinical based problem solver and know when to progress and when to regress. Most of the time it's progress, right? Most of the time we just make things tougher and we get better and it's great, but sometimes we have to regress as well. So how do we, as the PTA, how do we decide whether to progress or regress? Well, based on patient's subjective comments. So remember, I always said we're going to learn how to write SOAP notes later. The S part of SOAP notes stands for subjective. That's come from the patient. How are you feeling today? What do you think today? The patient's own words describe what's happening to them. Now, the patient's word isn't always, I'm not going to say it's not accurate because I think our patients for the most part are being truthful, except for the ones that don't want to get better. But let's just talk about pain for a second. Do you think pain is influenced by things other than the actual problem that they have? Yeah. Give me a list of things that could affect pain. Stress, absolutely. Could be pain tolerance, yeah, potentially. Medication, ran out of the pain meds, absolutely. What other things affect? Now, I mean, did stress, did getting into a fight with the spouse, or did running out of pain meds, did it change the problem that they had? No, the problem they had is exactly the same. It's just the other things that affected to it. Any others? We just said one. Overexerting themselves. After the first nice weekend in the spring, every single patient you ever have, that first night, it's only like 52 degrees out, but it's the first 52 degrees and sunny. Every single patient is going to overexert themselves, and they're going to come back in the next week, and they're all going to complain about something worse. Yes, absolutely. We said weather, right? Everybody feels better on sunny days. Everybody feels worse on rainy days. It doesn't matter, right? It doesn't matter what their actual problem is, right? So our patients' subjective comments on what they're giving us, it's valuable, and we shouldn't discount it. Anytime I've made a mistake, it's because I stopped listening to my patients, but it doesn't give the whole picture. It gives some information. We also use objective measurements, right? So that is you're saying your knee feels stiff today. I'm bending it further than what we bent it last time, and I'm using this tool to measure it, right? So that's a great example of the patient's subjective comments. Yeah, it feels stiff today. I get what you're saying. It's not matching what I'm seeing, though. So why do you think that's important? To be able to tell the two things and explain that to our patients? Just to tell them, you're lying to me, get out of here. No, why? Absolutely, because when that knee is stiff today, what is the patient fearful of? I'm not getting better. This isn't going the right direction. You say, hey, I know it feels like that, but actually it's moving great. I'm not concerned whatsoever. Sometimes they just need that "don't worry, bud" comment. Yeah, absolutely. So we take the patient's subjective comments, what they're telling us. We take our objective measures to see, like, okay, do we actually need to adjust our treatment or not? And we make that decision in consideration of the prognosis, considering the diagnosis, all of the contextual factors, the patient's prior level of function, medication schedule, weather, patient's better in the afternoon than the morning, all of that stuff factors into it. So, it's not easy to figure out all of that stuff at once. The great thing about, there's a lot of gray area there. So when we talk with our patients, there's oftentimes going to be more than one correct answer. And some of the ways you get better at making that decision is you have your 3 clinical rotations where you get to work side by side with your clinical instructor, and you're both hearing the patient say the same things. You're both taking the same objective measures. You both have the treatment plan in front of you, and you get to say, I would do this, CI, and the CI would say, I don't think that's the right plan. I would go this direction. And because they have more experience, we would listen to them, right? So that's part of the ways we get a lot better. Now, something I'm going to do today is I want to talk about how do we improve patient communication. Now, first thing I typically do in every class is I go around the room and we introduce ourselves and we say something fun about ourselves. Most of you have had class with one another already. There was, over the summer, there was a nighttime class and a daytime class at Kines. Who took the daytime class? And who took the nighttime class? All right. All right, so we got a good mix. So I'm going to talk about how do we improve patient communication, because it is an art. And that's one of the things that we don't get a lot of until you get to your clinical rotations. Now, I will be giving some information here. Sometimes I'm going to see something where I say, whoa, I understand this is just your lab partner, but if that was a patient, this would have been really wrong, right? So I'm going to try to clue you in on that when I see it. We're going to get a lot better once we sit in our first internship and actually talk with patients. But today, being the first day, this is something I want to start practicing with. So first, let's look at some of our interview techniques. The newer we are, PTA students and brand new grads, we often have a linear kind of thought process. And actually, that's exactly how I'm going to teach you for most of the things. I'm going to teach you step one, do this, step two, do this, step three, do that. Where when we start getting better at it, we get to just have a more free-flowing conversation. So if you guys were to come with me and see how I interact with my patients, I don't ask a lot of questions, but I have an in-depth conversation. And the conversation is going to go a bunch of different directions, but I know I'm going to get the information that I need eventually. When I was brand new, and exactly how I teach you, my first question is, tell me about your pain. My next question is, where is it? My next third question is, how bad is it? Okay, next I'm going to ask you how you did after the last time. Did you do your home exercise? Like I very rigid in my process. After that, it's much more free flowing. It's a lot like learning how to drive. You guys remember when you first learned how to drive? Step one, adjust the seat. Step two, adjust the mirrors. Step three, right? Do we ever think about that stuff now? No, right? So, the better we get at anything, the more free flowing we can be. I'm sure when you first started training people, you had a much more, this is my plan and I have to do that. And now just roll in and go with it, right? So, yeah, it's the way everything is, the way we get better with everything. So typically our patients are gonna be able to tell their entire story to us in 2.5 minutes. In that story, they're going to have things called dollar statements versus penny statements. Dollar statements are really important. We better make sure we understand those. Penny statements, I'm not really concerned with too much. But it's important to understand what we're listening for. So that we have a bunch of different types of questions we could ask. The better the question, the better the information we get. What we'd like to do is we'd like to stay away from closed-ended questions. Closed-ended questions, the answers are binary, yes or no, more or less. It really locks the person into one direction or another. So, is your shoulder pain present all the time? Have you fallen? Do you enjoy this class? That doesn't give a bunch of in-depth information, does it? Now, sometimes we will be needing to use this, but if I were to ask you to enjoy this class, first of all, everybody's answer would be yes. But that's not giving you the opportunity to say, like, I wish we could have a shorter break during the class, just get out at 4 instead of 4:30, because I got to drive to Providence. And not only do I have to fight traffic all the way down here, but then we have to fight traffic all the way home, and it takes me an extra hour. The difference between leaving here at 4 versus 4:30 is an extra 35 minutes of traffic. I wish we could just do that. Do I get that information if I just say, do you enjoy this class? No, I don't get that information, right? So what we'd like to do is ask open-ended questions where a patient gives us that narrative response. Tell me about your shoulder pain. What can you tell me about your balance? What about this class can we improve upon? Do you see how much better information we're going to get? Now, what's the downfall of open-ended versus closed? Who has a family member, there's someone's aunt that you go at Thanksgiving, I hope I don't sit next to Aunt Sheila, because if you just say hi to her, that's it. That's the next 2 hours of your life, right? So I can see the people who definitely have Aunt Sheilas in their families. So yes. They could have sprawling answers. It can take a lot of time. And guess what? My time is my money, so I need to be efficient with my time. And they're also going to give us, when we say dollar statements versus penny statements, a lot of pennies coming at us. So yes, it can be a real skill to guide our patients away from that sprawling. No, I don't care about your cousin and how they made you mad. I was asking, does your toe still hurt? Right? Now, sometimes we need to ask questions that clarify a response. Sometimes our patients are going to be vague. So graded response gives us an opportunity to clarify like vague details. The patient complains of shoulder pain that occurs after driving a long time. Who's native? Anybody not a native Rhode Islander? Anybody? Where are you guys from? Let's start with you. South Jersey. Connecticut, and Mass. Yeah, give it to me. So when we talk to a native Rhode Islander, and you guys that are from out of states can, even Connecticut will tell us, what's a long time to Rhode Islanders? How many people told their family members, oh, no, I go to CCRI. Oh, no, it's the Newport campus. How many people looked at you like you had three heads when you said, you got to go where? Right? All of us, right? So I had one patient when I was working on Aquidneck in Middletown. I had one patient that never left Aquidneck Island. He was born in Newport Hospital and he had never stepped foot off the island. What's a long time for that guy? But he was like 98 when I saw him. I was like, well, you can't leave now. Like you gotta run this thing out, man. You got So when we ask a Rhode Islander, how long is a long time? 20 minutes is like, oh, that's it. Like that's yeah. Anybody from South County? Yeah. What's the landmark that you've talked to somebody from South County? What's the landmark they say? You're gonna go past the towers. You guys know what the towers are? The ones there, yeah. Yeah. So man, if we talk to somebody from Rhode Island, man, driving a long time can mean something very different. South Jersey, it's a long time for you. Yeah, way different, right? So, man, we've really got to clarify that. Patient status of balance worsens later in the day. What time is later in the day? I have patients that wake up at 4 a.m. I have patients that wake up at 4 p.m. Well, if you're telling me your balance is worse later in the day, first, my decision is, do I want to work with them when they're bad or when they're good? There's some reasons for both. But when I'm making my schedule with you, what time is later in the day? Because if I think I'll be at your house at 9 a.m., for some people, that's later in the day. Other people, I'm just getting to bed at that time, right? So we've really got to clarify that. So that's what the graded response can. So, I think the real skill is being able to hear when someone's vague about that kind of stuff. And we just can't assume like, oh, well, that means driving past the towers, right? So anyway, multiple option questions gives a list for that patients can choose from. Anybody ever been a waiter, waitress, bartender? I went to JB's, by the way, last just a couple weeks ago. It was really good. When we give a patient a list of either specials or drinks, hey, I would like the beer. What kind of beers do you have? The server gives us a list. What does the person who's ordering always order? Either the first thing or the last thing of the list, right? So there's some flaws with that kind of a question, but sometimes it can help our patients who are either have Aunt Sheila's and they're just sprawling around with their conversation, or when we ask something they can't, like when we ask somebody to describe their pain, it's important for us because their description of pains can mean very different things. But sometimes that's a really odd thing to ask if you haven't thought about that. So we give them a list. Is it dull? Is it ache? Is it burning? Is it throbbing? Is it stabbing? Is it sharp? Like all of those things can give us different information and can guide our treatments, but I need that information. So we give them a list there, but there's still flaws with it. So what again, most of the time we try to use open-ended questions because we want their own words telling us and we don't want to lock them in to narrow their response. But sometimes like closed-ended questions or multiple option questions can be beneficial, especially for our patients post-stroke and have communication difficulties. They have trouble getting, they have a type of aphasia where they have trouble getting words out. Sometimes we can help them by just choosing a different one. But broadly speaking, open-ended would be better than closed-ended. I think we saw why. So here's our practice that I would like to do with you. I want you to talk to somebody you don't know. Okay, so if you had kinesiology with them and you know them, find somebody new and practice your interview type questions. See if you can come up with, the questions you'd like to ask about somebody, see if it's close-ended or open-ended. Is there a way, if it is closed-ended, can you reword it so it's open-ended? See if you can listen, or maybe you want to ask a graded response or multiple option question if there is something else. So anything you might want to know about your classmates. So just get to know someone new and practice some interview skills. Okay? All right, find somebody you don't know and start talking to them. So the last thing we'll say about patient interactions is just how important nonverbal communication is. I think that's something you read a lot from the sales world. So just share this one more time. So nonverbal communication can give us more about that interaction than just words. Roughly 55% of the meaning of a conversation comes from body language, 38% roughly from the tone of the voice, and only 7% are the actual words that we say. So I don't speak any language other than English. How many people speak more than one language? Anybody speak more than two? So it's always amazing me people who speak more than one language. I'm envious of that. I had this one guy, he only spoke Portuguese. And we'd say, okay, it was pretty simple treat for my world. I'd ask him to do some walking. I'd say, okay, it's a time when the patient doesn't want to move one more. I say, let's do one more lap. I always knew he was swearing at me and we weren't going to do another one. I had no idea what he was saying, but the reason I knew, okay, he's all done for the day, was not because of the words he said, but the body language and the tone in which he said it. So that's one reason why I think social media can be such a cesspool, is because a lot of it is text-based and not the full interaction. How many people got into a fight with somebody on a text message just because they interpreted the tone wrong, right? So it's really important for us to pay attention to our patients, pay attention to them fully. It can be more and more difficult, especially with computer documentation that we have to do. So just really make sure we're taking in all of that feedback from our patients. And then practices to avoid multitasking or distracted movements like playing with your hair, playing with the pen, spinning around, anything like that will show that to our patients that we're not interested in them. Even though that's probably not what we're meaning to, it can just cause some barriers that we don't want. All right, so here's some important information for us to review at some point. Not a lot of hard, this is the exam type questions, but this is stuff that we need for our entire career. Our entire career is the thought process behind why are we doing all this stuff, and then how do we actually communicate with our patients. That's the foundation of everything. So we're going to be talking about that stuff a lot. All right. So what I want to do now, let's take a solid 15-minute break. When we come back, we're going to start practicing with some vitals and dipping our toes in that water and seeing how we're going to be learning these new skills and applying them, okay? All right, let's take a 15-minute break.